Welcome to the webinar, everyone. We're just going to give a few minutes or a few seconds at any rate as people continue filing in. And I see folks are still popping in, so we'll just give it another 10-15 seconds or so. All right, so I'll get started with some housekeeping. But I am Rachel Shapira, and Alice Salon and I would like to welcome you on behalf of the NSGC webinar subcommittee to today's member webinar, Introduction to Genetic Testing, Genetic Counseling and Testing in Nephrology. Please know that everyone is muted as a courtesy to our presenter. We do encourage questions throughout the presentation. You can use the Zoom Q&A option or also the chat option, and we'll be doing Q&A at the end. I'm just checking on our participant numbers. All right. Today's learning objectives, if you could pop that slide up. Participants will be able to differentiate between different subtypes of kidney disease and identify the major indications for genetic testing in nephrology. You'll be able to recognize genetic conditions of the kidney and their unique counseling and genetic testing concerns, and also summarize the role of a genetic counselor in an adult nephrology clinic. And so I will now pass the mic over to Meg Hager from the Renal SIG to introduce our speaker.
Thanks, Rachel. Kelsie Bogyo is a genetic counselor at Columbia University Medical Center. She works with adult and pediatric patients with constitutional disorders, primarily with individuals who have kidney disease. She holds a faculty position as lecturer in genetic counseling and is engaged in teaching and supervising Columbia University genetic counseling graduate students in their nephrogenetics internship. Kelsie is involved in multiple research studies focused on understanding the genetic causes of kidney and liver diseases, for which she primarily interprets genomic data and returns genetic results to participants and providers. She also provides laboratory genetic counseling services for the Precision Genomics Laboratory at Columbia. Originally from California, Kelsie migrated east to complete her genetic counseling graduate education at the Icahn School of Medicine at Mount Sinai in New York City. And with that, I'll turn it over to Kelsie.
Thank you. Thank you so much, Meg. Thank you, Rachel. And thank you, NSGC and the Renal SIG for inviting me to talk today. I'm really excited to talk to you about this. This is, kind of my day today. So I'm excited to kind of share a little bit about what genetic counseling is looking like and what, types of genetic testing we're doing in nephrology. So I don't have any disclosures, and I just put the learning objectives again. Really, this lecture is intended to be an introduction into what what type of genetic testing we see in a kidney genetics clinic and in nephrology. And this is really coming a lot from my own experience working in our clinic within nephrology at Columbia. So the goal is really to go through these different subtypes of kidney disease that we see, when to, recognize, when genetic testing is indicated, and kind of unique considerations and counseling considerations that we see, and also to talk about, this is really a growing area. So what does a genetic counselor look like in this type of setting from our experience and from others' experiences as well. So I'm sure, everyone has some idea of the kidney, but I just want to kind of take it to the very beginning to start off with, just to chat a little first about, what does the kidney do and chronic kidney disease. I'm sure, at some point we've all learned about this. So kind of the functional unit of the kidney is the nephron. And, each kidney has about 1 million nephrons. And the nephron is composed of these other units, which each have very particular functions. So the glomerulus, the tubules, the collecting duct, and the kidney has a lot. It's very important. It has a lot of different functions in the body, removing waste, regulating water retention and electrolyte retention. Which regulates blood pressure, but it also makes vitamins, releases hormones, and controls the production of red blood cells. But what we're really talking about today is kidney disease. So, what happens when it's not functioning correctly. There are, multiple, common risk factors for chronic kidney disease, CKD, and those, include hypertension, diabetes, autoimmune conditions like lupus, and then, of course, social determinants of health play a role in this type of chronic health condition. Chronic kidney disease is common, so 15%, and this is from the CDC, 15% of adults have chronic kidney disease in the US. So that's 37 million people. And it also disproportionately affects people who are Black, Latinx, and Indigenous. So, that's where these social determinants of health and health inequity really play a role as well. In terms of testing for CKD, there's a lot of different types of diagnostic tests in order to determine if CKD is present. Blood tests, urine tests, imaging, biopsy, and I'll kind of mention all of these throughout my talk today. But one type of blood test that I think is important to mention is an eGFR, so estimated glomerular filtration rate, which is really staging the kidney disease in terms of kidney function. So for this talk, I want to differentiate between kidney disease and chronic kidney disease. So kidney disease is kind of, I refer to it more broadly, like for example, polycystic kidney disease or congenital anomalies would fall under the umbrella of kidney disease. But when I'm talking about chronic kidney disease, that really refers to kidney function or how much kidney impairment there is. So someone with polycystic kidney disease can have normal kidney function. They don't have any chronic kidney disease. So I want to differentiate between that. The eGFR really breaks chronic kidney disease or CKD into these stages, with the last stage being kidney failure or end-stage renal disease, ESRD. And this is the point when someone would require dialysis or a kidney transplant. So different diagnostic tools are used in order to diagnose kidney disease. So imaging is going to be more important in congenital anomalies or cystic disease. I also want to kind of mention the difference between clinical diagnoses. So I'll mention a lot of different clinical features, biopsy features, things like that, and how they are different from a genetic diagnosis. So something like nephrotic syndrome, which is really a diagnosis that's made based off of clinical features, versus a diagnosis of focal segmental glomerular sclerosis, which is a diagnosis made based off of a biopsy. And all of these kind of overlap, and they overlap with genetic diagnoses as well. So where a lot of this really started, especially in our clinic, is through this paper that was published in 2019 by Grootman et al., who started testing individuals with chronic kidney disease by exome sequencing. And they found that 10% of people who in their cohort, almost 10% of people who had chronic kidney disease, they were able to identify a diagnostic variant or a genetic etiology for their kidney disease. And so that really sparked a lot of interest. You can imagine, as I told you before, 37 million people in the US who have chronic kidney disease. This is an extraordinary large number of people. So it has a lot of implications for people's health. And so based off of that, we started implementing projects to start returning those results from genetic studies, and then eventually in our clinic to start seeing people on a clinical basis for clinical genetic testing. So these are kind of these subtypes of kidney disease that we use to understand kidney disease, genetic kidney diseases, and to really break them down and help us in the diagnostic process. So they're not necessarily hard and fast rules. A lot of these subgroups can have overlap between each other. Genes can sometimes cause cystic kidney disease, but maybe sometimes that genetic condition can also cause a glomerulopathy. But these kind of, I think, are a way to start understanding how these conditions really affect the kidney and the development of the kidney. So I'm going to go through each of these conditions and kind of talk about what are the common conditions that we see, what are the specific counseling and testing implications that these would have. So I'll start with congenital anomalies. So congenital anomalies of the kidney and urinary tract, or CACT, they make up a significant proportion of pediatric ESRD, so 40 to 50%. So this is really important in the pediatric population, but also in the adult population. So 2 to 7% prevalence of CACT among adults. And it's really a broad category of all different types of things that can kind of go wrong during the development of the kidney. There can be unilateral or bilateral agenesis, hypoplasia of a kidney, dysplastic or cystic kidneys, duplex kidneys. So of course, imaging is going to be really important to identify this. A lot of people, even adults, are incidentally, they might, have some sort of other reason why they undergo abdominal imaging, and they're incidentally found to have CACT, and that's when they come to us. So because this is a congenital anomaly, I'm sure, people are really familiar that there is definitely indication for testing here. And about 20% of individuals with CACT are found to have an underlying genetic cause, especially in the pediatric population. There can be environmental causes as well. So we kind of have to take a full history to understand this. And one of the major causes of CACT are copy number variants, which is probably not surprising to most people because it's a congenital anomaly, and this is, microarray and things like that are something that we use to diagnose these. And this is a figure on the right that was put together to look at all of the copy number variations across the genome that involve the kidney, and they also involve most of the time other organs. So either, they might have neurodevelopmental implications or heart features as well. So most of the time when we're thinking CACT and a copy number variant, of course, if we're seeing an adult, we want to take a step back and say, well, are there any, developmental delays? We might want to take a prenatal history or understand if there were any health conditions that may have resolved by now based off of surgery or something like that, but may have been an issue when they were a child. So we try to take a step back as well, but there's also monogenic causes, and some of these can be syndromic as well. Other times they can actually be completely isolated to the kidney. So testing, it's really going to depend on the patient and what type of features that they have, but can usually involve some combination of a panel or an exome or microarray. So the cystic kidney diseases are also a very broad category. I can't really talk about cystic kidney diseases without talking about ciliopathies. So cilia, of course, I'm sure many people are familiar, are present throughout the body. They have important functions in many, many different cell types. And therefore, a lot of ciliopathies tend to also be syndromic. But one of the ciliopathies is actually polycystic kidney disease. It makes up the PKD complex in the cilia. And the cilia are also particularly important in the kidney. They're important during the development and also for kidney function and in sensing urine flow. So these are some of the different ciliopathies that we might see, some of them with renal manifestations like different types of cysts and large kidneys, sometimes also with congenital anomalies as well. And many of them can also have extrarenal manifestations. But I'm going to talk mostly now about PKD, because this is really something that we see common. It's a very common condition, especially ADPKD. So again, this is based off of ultrasound findings for the most part. And there's pretty typical ultrasound findings that you might see for someone with like classic autosomal dominant polycystic kidney disease. So this would be enlarged kidneys, very large, with innumerable cysts on both of the kidneys. So based off of the imaging, they can actually make a diagnosis of this, also in combination with other factors like a family history. Cysts, there can be cysts in other organs as well. In the liver particularly tends to be affected as well. In ADPKD, they can be, benign liver cysts, or it can also cause polycystic liver disease, which might cause liver failure. And then there's other condition-specific features that we look out for, right? Like hepatic fibrosis and ARPKD and intracranial aneurysms and ADPKD. So I put this slide on here to kind of show the difference between ADPKD, ARPKD. I think historically, we really think of ARPKD as neonatal onset, and typically that's true. There can be enlarged kidneys, hepatic fibrosis, and prenatally, the biggest issue can be a Potter sequence. In ADPKD, we think mostly of PKD1 and PKD2, but there can be other genes as well that cause this condition. And it's quite common for a genetic condition. About 1 in 1,000 individuals have this. Generally adult onset, but there's always, there are sometimes childhood onset ADPKD. So we saw this patient in our clinic. He was a 43-year-old man. He had CKD when he was diagnosed with CKD when he was 30, and he ended up receiving a kidney transplant when he was 37. The donor was his brother. And we had imaging from his native kidneys. So they had bilateral cysts. He also was noted to have hepatic echogenicity and splenic varices. When we asked him further, it wasn't totally obvious, but when we asked him further, he actually had been diagnosed with congenital hepatic fibrosis, but it wasn't really an issue for him currently. Really what he was dealing with was the kidney disease at this point in his life. And he didn't have any family history. So at 43, he was diagnosed with ARPKD. We found that he had biallelic PKHD1 variants. So really this is to show, people can be diagnosed at many different stages of life. And we think of this as maybe an issue for children. And while it was for him, it can also, present with issues later in life as well. This patient was a little more of kind of a classic diagnosis of ADPKD. So she was a 69-year-old female, and she had a clinical diagnosis of ADPKD. So that was based off of imaging and her family history. So she had imaging that showed, classic ADPKD findings. She had innumerable bilateral renal cysts. She also had some liver cysts. And she had a strong family history of PKD. So her mom had PKD. Her mom had already passed away. Her sister was diagnosed pretty recently with PKD in her 60s. And then she wasn't quite sure if her maternal grandmother had PKD. She said maybe possible, but she passed away when she was in her 40s from an aneurysm. So based off of the family history of having an aneurysm, she was already, and a clinical diagnosis of ADPKD, she was already screening for them with brain MRIs, but they had been normal. But the most important thing for this patient at this point was that she was approaching ESRD, and her daughter was her potential kidney donor. So her daughter was starting to be worked up as her donor. But given the family history, the donor team and the family really wanted to know whether her daughter was at risk, because it seems that everyone in the family is being diagnosed in their 60s. So it's possible that her daughter, when she's still 40, might not, she would have renal imaging as part of the workup to be the donor, but it's possible she might not have cysts at this point, but could still be predisposed to having cysts. So we pursued genetic testing, and this patient was found to have a pathogenic variant in PKD2. So PKD2 is a slightly more mild form of ADPKD, and I say mild to refer to the fact that people tend to progress a little bit later in life, and that's consistent with the family members kind of being diagnosed in their 60s. So it's causing a little bit of a later onset, although we do know, there's genotype phenotype correlation between the type of variant and the age of onset of ESRD. So they had a truncating variant in this family, which is a little bit more severe, causing a little earlier onset. So we also tested her daughter. Her daughter was really interested in understanding these findings, and she ended up being negative for the variant. So this was really, really wonderful news for this family. They were excited to be able to move forward with her daughter as the donor. And, our patient, the mom, she was just really happy to have an answer and to know that her daughter was going to, be okay, that she wasn't going to have to deal with this condition. So it was really good news for this family. So genetic testing for polycystic kidney disease can be a little bit complicated because there's a lot more genes than we typically think about. It's not just PKD1 and PKD2. A lot of other conditions can cause kidney cysts. So we have to keep those in mind and kind of think, is this a very typical ADPKD presentation, or is there something atypical? Is it possible that it could be something else? PKD1 is also a very complicated gene to test for. It has multiple pseudogenes. So some labs might leave it off of their testing if they're not able to perform appropriate testing for it, which can usually include things like confirming the variants with long-range PCR. The other thing is that PKD1 and PKD2 are really, really large genes. So people having VUSs in them is not uncommon. It's quite common for people to have them, but makes it very confusing, when someone has clinical features. There are a lot of kind of private variants that have not ever been reported outside of that family. So it's possible that this could be the answer, and that we just don't have the data in order to classify it as pathogenic. Or it could also be one of those kind of common PKD VOSs that's benign. So it's hard to interpret them, and it's especially hard, I think, for our patients to interpret it in the previous scenario, if they're thinking about this in terms of transplant, when they really want to make decisions based off of these results. And I think that's a really unique aspect of genetic testing in kidney disease, is the way that it can be used in transplant decision making. So there's lots of other, large deletions, small deletions, gene-specific things that we need to take into consideration. And the diagnostic yield is really going to depend, it's very variable. And again, it depends on other factors, like do they have features that are really specific for one particular condition, or do they have a family history, things that we're pretty familiar with in genetic counseling. And I point this out as well because there is a drug therapy for ADPKD, which is tolvaptan, and it is used to slow the progression of chronic kidney disease in ADPKD. Genetic testing is not required. People can start this medication based off of a clinical diagnosis, but we've actually found in a couple of our patients that we saw, their insurance company denied coverage of tolvaptan for them because they didn't have a family history, which of course ADPKD can be due to de novo variants. So we were able to do genetic testing to show that they did have ADPKD. They met those diagnostic criteria, and we were able to successfully appeal the insurance company's denial, and they were started on tolvaptan. So that was really exciting. So I'm going to move on into kind of a different area, which is the glomerulopathies. So these are really just a group of conditions that are affecting the glomeruli. So this is really the portion of the nephron that's filtering the blood. So typically, there shouldn't be any blood or any protein leaking into the urine. And so urine tests can be really helpful in these types of conditions. If we're seeing that there's blood or that there's protein, it can show that there's issues with the glomerulus, or there's damage to the glomeruli. There are a lot of different genetic conditions that I would consider glomerulopathies. One of the big ones that I'll talk mostly about is alport syndrome or col4a related nephropathies. But there's Fabry, there are immune related glomerular nephritis, so genetic conditions that affect the complement pathways, amyloidosis, and podocytopathies, or that includes kind of the spectrum of steroid-resistant nephrotic syndrome. So I'm going to talk mostly about alport syndrome. This is from our clinic, kind of a very common referral, and we're actually finding that it's much more common than we thought it was. So classically, it's described mostly as the X-linked and the recessive forms, but there's 3 different genes and 3 different inheritance patterns. So it can be complicated to counsel about these conditions, but it's col4a3, 4a4, and 4a5 that are implicated in alport syndrome. And the features are really a trifecta of kidney disease, eye findings, and ear and hearing loss. So the kidney disease, a lot of times when I talk to people, they'll tell me, yeah, I have hematuria, blood in the urine, and they may have known about that or had that for years. A lot of people say, I've had this as long as I can remember. Whenever I go to the doctor and they do a urinalysis, it's usually microscopic hematuria. They're told of it, but they're told it's not so much to worry about. The kidney function is okay. But these individuals, so that's really, one of the first features that we can see. they might have proteinuria. And then kind of the classic biopsy finding is thinning of the glomerular basement membrane or kind of textural abnormalities that are affecting the glomerular basement membrane. And when we see this on biopsy, it really specifically points towards alport syndrome. So a lot of our referrals now sometimes come from the renal pathologists who notice this on biopsy and are able to say, I think maybe they might have alport syndrome. They can also have other types of biopsy findings. I mentioned this before, focal segmental glomerular sclerosis, which is a pattern of injury or scarring that's seen on the kidney on pathology. The pathognomonic eye finding is anterior lenticonus. And generally, it's not all individuals have it. About 15% of people who have X-linked or autosomal recessive Alport syndrome. And then also progressive hearing loss is also quite common in people who have X-linked and autosomal recessive Alport syndrome. Now, there's also autosomal dominant Alport syndrome, which is maybe a misnomer in terms of how we're talking about inheritance here. Essentially, they're people who are heterozygous for a pathogenic variant in COL4A3 or 4A4, and a lot of them end up having features. So I kind of put this here as a little bit busy, but just to show the differing features between X-linked, autosomal, recessive, dominant, and there can also be digenic inheritance as well between these genes. But the biggest factor, when I'm talking to patients, what it always tends to come back to is what's the risk for progressing? What's the risk for kidney failure? And so this gives us a little bit of, information we can see based off of the inheritance patterns, how it's different in X-linked and autosomal recessive. It's almost 100% chance that someone will progress, although the age of progression varies significantly, and there's a lot of genotype-phenotype correlation between different types of variants. So missense variants lead to later onset, and even different types of missense variants can lead to even later onset. There's hypomorphic alleles, variants. So there's a lot of variability within here. So we can, try to give our patients as much information as possible with this. Heterozygous females who have variants in COL4A5 or the X-linked form also have a risk for ESRD. And in the dominant form, I will point this out because we do see the autosomal dominant form quite a bit, and we're actually finding that people who have kidney disease or kidney failure related to the dominant form is more common than we thought. So when people start to progress, to have other risk factors for progression like proteinuria or more severe biopsy findings like FSGS, their risk for progressing goes up. So this is a family that we saw in our clinic. We saw this individual down here who had microscopic hematuria their whole life, but they had just recently developed proteinuria, and that's why they started seeing a nephrologist. When we asked about the family history, they had a huge family history affecting all women in the family, but it was just a lot of women in the family in general. So you could see, there was kind of a dominant form of microscopic hematuria, although there was no chronic kidney disease or kidney failure in the family. And when we did testing, we confirmed. So we tested a couple people in the family and did confirm that they have autosomal dominant Alport syndrome. And I think, on one hand, our patient here at the bottom has proteinuria. She has one of these risk factors for progressing. But on the other hand, we can be a little bit reassuring in that her grandmother, who is 89 years old, still has normal kidney function. So, it really varies within the family and kind of depends on the other risk factors that are present. So there have been a couple ideas of how to talk about Alport syndrome and these COL4A collagenopathies, because there's a larger spectrum than what we were realizing in previous years. So, in the first option, it's possible that we could think of it as kind of a broader phenotypic spectrum of these COL4A related disease, and only some of those variants cause alport syndrome, and others, heterozygous variants cause isolated FSGS, or focal segmental glomerular sclerosis, with no other features of alport syndrome, and no other extrarenal features. How we tend to think about it in our clinic, at least, is that there's just a really broad phenotypic spectrum of alport syndrome, ranging from what previously was called benign familial hematuria. The past family, probably in the family from the last slide, probably would have been diagnosed with that. We're just seeing families with a huge history of hematuria. It was considered benign, although that's kind of a misnomer, or they were diagnosed with what was considered a benign condition, thin basement membrane nephropathy. But we're starting to think now that those are all part of the spectrum of alport syndrome, as we're identifying that they have maybe in the milder forms, heterozygous variants in the COL4A genes, and that on the more severe end of the spectrum is like X-linked or autosomal recessive alport syndrome, where we have early ESRD and also those extrarenal manifestations. I will also mention this group of conditions which are molecularly characterized as podocytopathies, but a lot of times they might present as nephrotic syndrome. For example, in PHS2, probably a lot of people are familiar with MPHS2 related steroid-resistant nephrotic syndrome. They are other genes that are associated with, for example, autosomal dominant forms of FSGS. So that's that biopsy finding again. So, all of these genes are in some way related to the normal function of the podocyte, and when they're not working can lead to this group of conditions. In kind of molecularly characterizing them, more classically, they were characterized by the clinical features, and then they might be trialed on steroids to see if it's steroid responsive or steroid resistant. But in knowing the genetic etiology of the condition, if there is one, you might be able to say, well, these genetic conditions in general are unlikely or less likely to be responsive to steroids. So, knowing this might, change the idea of progression as well. There's a high risk for progression, but a lower risk for them to have recurrence of disease after transplant. So it can give us a little bit more information instead of doing kind of a trial and error type thing. So I'll move on to a group of conditions that I'm kind of grouping together, but really are kind of separate. So they're the tubulopathies and the tubulointerstitial kidney disease. All of these affecting the tubule, of course. So the tubules really are in charge of reabsorption of electrolytes, water, balancing, acidity, and fluid and waste and things like that. So there's a lot of transporters along the tubules, and if those aren't working due to a genetic variant, can cause these tubulopathies. So a lot. I give a couple examples of them, but I'm not going to go into so much detail because there's so many of them and they're all very different. But some of them might have very particular laboratory abnormalities because it's a particular transporter in the tubule that isn't working. For example, Gittleman syndrome, the classic lab abnormalities are hypokalemia and hypomagnesemia. So when a nephrologist sees that, they might be able to say, this kind of looks like Gittleman to me. And that's what it might be suspected, because a lot of these are also autosomal recessive. There might be no family history of them. I'm going to switch gears a little bit to talk about autosomal dominant tubular interstitial kidney disease, or ADTKD, which isn't, I wouldn't necessarily call it a tubulopathy, but it is affecting the tubules in that there's this interstitial disease or fibrosis of the tubules that we're seeing. And the characteristics of it is that there's, of course, tubular interstitial kidney disease, which is can sometimes be difficult to really identify the etiology of it. You might have a urinalysis that shows a little bit of protein and no hematuria, and the biopsy might show that there's interstitial fibrosis or maybe just, generalized damage to the kidney. And an ultrasound might not necessarily find anything, very indicative of this condition. But, we see it in families and they do end up having progressive kidney disease, progressing to ESRD, very variable age range, anywhere between the 4th or the 7th decade of life. A lot of these individuals also have elevation of uric acid in the blood, so hyperuricemia, and they have gout because of that. Now, another piece of this is that you kind of have to pick apart how long have they had gout, because a lot of individuals who have advanced kidney disease can also develop gout as well. So a lot of these tend to be kind of non-specific, and they can end up being diagnosed with kidney disease of unknown cause sometimes. We see a lot of that as well. But the most important and the most striking feature is the inheritance pattern. So I would say a classic family history is a family history with, just dozens of relatives who've suffered from kidney disease. And you can see in this family, all of these people, the person that we saw had kidney disease in their 20s. It was CKD of unknown cause. And they had a strong paternal family history of all of these individuals who had CKD and also ended up being transplanted in their 30s and their 40s. And there was one uncle who had genetic testing, but had not been able to identify a cause for it a couple of years ago. So ADTKD, we really think of it being caused by 3 different variants in 3 different genes. And like I said, a lot of them can be associated with hyperuricemia and gout, but there can be other features related to each of these genes. So ADTKD associated with REN and SEC61A1 can be associated with other extrarenal features, as well as HNF1 beta. So I'll talk about HNF1 beta a little more specifically here. I think it's we talk about HNF1 beta a lot when we talk with our nephrologists, because I think it's a really good teaching example of a genetic condition, because there's so much going on in the condition. It's called many different things. It's a type of MODY as well. So it causes early onset diabetes. It's also been called renal system diabetes syndrome. And it can sometimes also be due to a microdeletion syndrome that can cause other features like behavioral and developmental delays. And the renal features are all over the place. They're really broad. So I've been trying to put the renal features into these categories, but HNF1 beta just really spans all of them, because it can be associated with CAFKIT. It can be associated with cystic kidney disease, and it can be associated with ADTKD and other issues with that. There's of course, features of diabetes. We use this to kind of make an example of like a family history that really can be, there's a lot of variable expressivity. Some individuals, might not have the renal features. They might only have early onset diabetes. And when you're asking about a family history, most people, I would say, will tell you, they have at least one family member who has diabetes. It's not a rare condition, but what you really need to ask for is how old were they when they developed? When we're starting to see multiple individuals who had diabetes, Were they diagnosed in their 20s? All of them diagnosed in their 20s and 30s, because that's when we start to say this is a little bit suspicious. And this is also an exception to that characteristically strong family history, because about 50% of the variants are de novo. So there can be absolutely no family history as well. So there's a lot of different kind of counseling aspects that go into this, things to consider. So I think it's important to mention, because you can see it really in all parts of someone's life. The other type of ADTKD I wanted to mention specifically was ADTKD related to MUC1. So this one is specifically, I wanted to mention this one because panels might, NGS panels might include sequencing of MUC1, but because of this really complicated variant, it's likely that sequencing is not going to pick up variants in MUC1. So the typical variant in MUC1 is located within a variable number tandem repeat within the gene. And it can be located in different locations within the VNTR, but it generally is an insertion which causes a frame shift and an early truncation. And the mechanism for disease is that they cause this mutated protein, this MUC1 frame shift protein, which builds up in the cells and is toxic. What we always say, especially with these strong family histories, if we're really considering ADTKD, is to follow up. And there's really only one place in the country that's doing testing for this at this point, to follow up for a targeted assay to detect if there's a MUC1 variant, because it's very likely that a sequencing assay would miss this. But I will mention, in this case where the mechanism is toxic buildup, that presents an opportunity for targeting with a drug target. This is just showing that they were able to promote lysosomal degradation of the MUC1 frameshift protein. And so this really kind of, I think, offers hope for these families that there is possible targeted treatments in the future. So the last group that I'll talk about, and I've talked a little bit about this, is kidney disease of unknown cause or unknown etiology. And this pretty much means that the person has CKD, so they have impaired kidney function based off of their labs, but their workup has been unrevealing for a cause for that. So they don't have any of those significant risk factors that I mentioned, like diabetes or hypertension, and their exam and testing has been consistent with CKD, but is not really pointing to any pattern. They might have normal imaging of their kidneys, so there's no cysts, there's no congenital anomalies, and they might have either not had a biopsy because it's an invasive procedure. There's many reasons why someone might not have a biopsy, or the biopsy could have just shown just non-specific kidney injury, and it didn't really lead to a more clear diagnosis. So from the first paper that I mentioned in this talk by Groupman et al., they actually found one of the really interesting findings was that they found, in addition to about 10% of people having, people with CKD having a genetic etiology, they also found that about 17% of people with kidney disease of unknown cause had they had a genetic etiology as well, which was also very high. So Hayes went in and looked at the literature, and of 443 people who had kidney disease of unknown cause, a chronic kidney disease of unknown cause, in the literature, they were able to find that about 21% of cases through genetic testing were able to figure out what was the cause, which has huge implications for treatment and, all aspects of their management. And you'll see that broken up here. These are the the genetic etiologies that were found. So there's a lot of alport syndrome, but it really ranges across all of the subtypes of kidney disease that I've been talking about. I will note that, a lot of these studies had been selected for family history or people, having a suspected hereditary nephropathy just based off of other factors. So that probably sways it a little bit high. So in kind of going through all of these, we've really talked about, determining the genetic risk based off of the kidney disease subtype. But of course, we have to take in all other considerations. And there's huge ranges in the literature of the diagnostic yield of people based off of these different subtypes of kidney disease. And the reason they're so large is because, there's so many other factors to take into consideration, as genetic counselors that we need to consider, including, do they have a syndromic phenotype? Do they have extrarenal features? Are they extraordinarily young to have kidney disease? Do they have, a pattern of kidney disease that's really specific for a particular genetic cause? And do they have a family history? Probably most importantly, do they have a family history? So I'm going to be mindful of the time, but I'm quickly going to talk about, I feel, that it's important to talk about risk factors, because this is something that's really been coming up in the community a lot, particularly the APOL1 risk factor. So if you're not familiar with this risk factor, it is a risk factor. It's most common in people who have sub-Saharan and West African ancestries. About 14% of African Americans have 2 copies of the risk allele. So essentially, it's a recessive mode of inheritance. There's 2 different alleles. So the G1 allele is actually 2 different variants in cis, and the G2 allele is an in-frame deletion. And so a high-risk genotype for APOL1 would be someone who's either homozygous for G1, homozygous for G2, or compound heterozygous for G1, G2. This particular risk factor has been shown to increase the risk for kidney disease, for FSGS, and for end-stage renal disease. And having the high-risk genotype is associated with earlier progression and faster progression to end-stage renal disease. And one of the biggest implications that this is having right now is that it is in transplant. So there have been studies showing of people who are transplanted, it depends less on what is the APOL1 genotype of the individual who's receiving the transplant. But it's most important, or more important, so you'll see up here the individual who's donating, or the genotype of the donor kidney. So if they carry the high-risk genotype, the kidney survival appears to do worse. So this is kind of one of the things, and this is really information that's coming out, from many different studies. So there's this longer term study that's really trying to understand the long-term outcomes of this. So this is the Apollo study. It's the APOL1 long-term kidney transplantation outcomes consortium. And so they're leading a lot of an observational study of people who are transplanted and have APOL1 high-risk genotypes, and coming out with guidelines about how to test for people, who should be tested, and how should they be counseled, and how should we make decisions about selecting donors and things like that, because it's really complicated and difficult decisions at this point. But we're already getting these results because APOL1 is on a lot of tests already. So we have to think about how to counsel them. In general, we're talking about their risk. We're talking about transplant. We're also talking about this as a risk factor, as opposed to a monogenic condition, that it may explain their kidney disease in part, but it's usually not the only factor. It's kind of more multifactorial. But there's still issues that come up with this. So how do we follow up with people who, this may have implications for their kidney transplant, but they're not anywhere near ESRD. So how do we deal with that going in the future? And I'll mention this as well. It's not just for people who are ordering genetic testing for kidney disease. 23andMe also reports on APOL1 risk factors. So it's something that your patients might be coming to you with. So I think that, all in all, there are a lot of implications for genetic diagnosis in nephrology. Most of these are, they overlap with other subspecialties, but I think unique to genetic testing in nephrology is that there's the potential, to maybe help clarify the diagnosis, help with the biopsy, or maybe try to avoid biopsy if they're using it for diagnostic purposes, since it is an invasive procedure, and also to assist in transplant selections, especially in families where we have a large family history. And I'll kind of close out talking about some of the kidney genetics clinics that have popped up around the country. And also around the world. So, this is kind of a really growing area where genetic counselors are starting to work with geneticists, with multidisciplinary clinics, with adult and pediatric nephrologists to really start to offer to reduce barriers to getting this genetic testing and to offer testing for their patients. And a lot of them report some really positive outcomes for their patients. And we also have established a kidney genetics clinic within nephrology. So our model really is we work with adult nephrologists. The ones we see full consults with have kind of special training or special interest in genetics. And we have full consults, counseling and testing for them. We've seen we had over 400 people, adult patients referred. We also see pediatric patients, but just adult patients over 400. And so far, quite a few people have been able to find an answer for what has been going on. And that's really something that comes up a lot is that people, even if it doesn't change their management, they're looking for an answer, which I think is not necessarily unique to us, but it's an important reason for why we offer our services. So if you have any questions, please contact me. But at this point, I'm going to stop with the time in mind and open it up to any questions.
It looks like we've got a few questions in the chat already. So thanks again for the wonderful presentation, Kelsie. So one of the questions that we have is, I guess, choosing panel size. Are you typically seeing that yourself and other providers are using large panels that cover all the potential genes that relate to CKD? Or are you using smaller, more targeted panels, since there are quite a few labs that are offering panels that are over 300 genes, so sometimes it's hard to select?
Yeah, I mean, I personally tend to err, especially working in nephrology. And as I mentioned, there's so much, these subtypes are not, perfect partitions between the types of kidney disease. There's a lot of overlap, and there's probably more overlap than we even know. I tend to order larger panels unless, there's certain circumstances. I think it involves the counseling process. I've had people actually with these huge panels. I also talk about incidental findings. We've had incidental findings on large panels. I've had people who have a family history of sudden death, and they are not interested at all in knowing that. And so we said, okay, well, we're gonna, look for a more targeted panel with the limitations. We might miss something, but it was more important that they didn't. But yes, I do tend to find myself ordering larger panels. It comes with a lot of uncertain variants. But we spend a lot of time in our clinic looking through VUSs as well. And if you notice, I put on one of the slides, the last slide, I think, that 20% have diagnostic positive. We also count candidate diagnoses. So these are people who have a VUS and a gene, and there's either a little bit of preliminary evidence, it's called a VUS, but maybe there's preliminary evidence, or it fits their phenotype really, really well. And this is just based off of our clinical experience. that we think that this could be it. And we really make note of that. And we hold ourselves accountable, and also the referring nephrologists, we work closely with them to talk them through these results and what they might mean.
Thanks. It looks like another question that we have specifically relates to, excuse me, autosomal dominant PKD. So if a proband is suspected of having ADPKD and they get an uninformative negative test result, what would be the process for determining whether a first degree relative could be a donor, or would they still have family members that could be eligible to donate at all?
Yeah, so I don't know all the criteria from, in terms of the transplant team. We do work with the transplant nephrologists to kind of be part of that donor workup. And sometimes, they say genetic testing they feel it's important, an important part of that workup. If the proband has ADPKD and they get a negative result, I mean, their family members would still be eligible, and they would still have, imaging of their kidneys and a full workup to make sure they don't have any kidney impairment or other health issues. So like the donor workup is very extensive. There's also criteria, as someone gets older, the likelihood obviously of them having ADPKD and having absolutely no renal cysts will go down. So it's possible at a certain point to say with a lot of certainty that they probably don't have ADPKD. But, sometimes they're just kind of, and we do get that, sometimes people who have VUS and PKD1, and we just really have no data on it. And it's really difficult.
Thanks.
So I know we have a bunch more questions in the Q&A, and it's about 1 minute after 2. So I was going to say, if it's okay with Kelsie, Meg, if you see one more that looks like a really good one to address for the group. And then, of course, everyone has the resource that the Renal SIG resource that Meg shared in the chat, and Kelsie's email.
Just the other big question that I see is, aside from age of onset and a few other, like assessing other risk factors that people might have, are there any specific family history questions that you're asking to determine whether a kidney disease is more likely to be genetic or not, or kind of what are the big features that you look for that would tip you off that this could be genetic?
Yeah, I think it mostly falls, if there's a family history, of course. If there's, kidney disease is not, as I mentioned multiple times, unfortunately, it's not rare. So people can have a family history and it can be unrelated. I like to try to get as much information as possible about their family members' kidney history. Do we know what caused it? Did they have a transplant? Did they have a biopsy? Can you share that with us to try to figure out if it's related or not? So I do tend to get a lot of more detailed information about that. In terms of risk factors though, I think it's mostly going to be, is there anything that's standing out? For Alport syndrome, biopsy results come to us a lot, or even just CKD where there's absolutely nothing. And at this point where we can say, genetic testing is a little more accessible, so we can try to, order a panel and see if we can find any sort of cause that's going on. Cystic kidney, our highest yield from this slide, actually, you can see our highest yield is in cystic kidney disease and those who are suspected to have a collagenopathy. So I would say if you take anything away, those are the ones to really think about, would be like Alport syndrome, any features like that, or any type of cystic kidney disease, cysts in a young person, or bilateral cysts at all.
All right, so then thank you so much, Kelsie, for answering all those questions and for the amazing presentation. So this concludes today's member webinar. The NSGC webinar subcommittee would also like to announce the June 2022 episode of the NSGC podcast series, which is titled Advocating for the Intersex Community, How to Begin Dismantling a History of Harm. There are 3 different speakers, 2 of which are recent graduates, Darius Hagigat and Kayla Horowitz, and genetic counselor Rebecca Freeman. The podcast speakers will share findings from their capstone and thesis projects, surveying or interviewing members of the intersex community, as well as parents of intersex children. And on behalf of the NSGC webinar subcommittee, I want to thank you all for attending, and a huge thank you again to Kelsie. This webinar recording will be posted to the webinar page of the NSGC website within 48 hours. Have a great rest of your day.